introduction. So I felt that this would be a very practical topic for all practicing nephrologists, a thing which we commonly face in our OPs and during our ward rounds. So I will directly go to this case. So this is a 67-year-old female. She has poorly controlled diabetes. She has CKD stage 3. She had presented with septic shock and on evaluation was found to have right pyelonephritis with hydroureteronephrosis. So she was stabilized. She was treated with inotropes, appropriate antibiotics, and the culture results had come, which had shown that it was a Klebsiella pneumonia, which was sensitive to carbapenem. She responded very well to treatment. She also had to undergo a right DJ stenting because there was right pyelonephritis with an HUN. For better drainage, a right DJ stenting was done, and patient is in improving trend. So now she has completed day 14 of her intravenous IV antibiotics. She is asymptomatic. She is all better. On clinical examination, there is no renal angle tenderness. During hospital stay, she had an acute worsening of her CKD, which gradually resolved. But the problem arises here. This is day 14 and a urine routine was done. A urine routine shows an albumin of 1+. Urine pus cells were numerous. Her total count on this day was 6,500. She was afebrile. Neutrophils were only 60%. Blood sugars are well controlled. So what will be your next step? A very common scenario that we see when we follow up pyelonephritis patients. Jyotipriya, over to you.
Okay, so moving on to the first poll. Martin, can you just move on to the next slide? So the first poll is pyelonephritis patient after 14 days of IV antibiotics presented with asymptomatic pyuria. What will be your next step? Option A, send repeat urine culture and sensitivity. B, continue IV antibiotics for 1 more week duration. C, start oral antibiotics for 1 week and review. D, review after 2 weeks with urine routine and other parameters. E, send for a gynecological evaluation. Dinesh, can you launch first poll? Poll 1. Yes. So the poll 1 is on the screen. 5 options are there. Okay. So I think time is up. So Dinesh, you can close the poll and launch the results. So majority have opted to review after 2 weeks with urine routine and other parameters. Almost, okay, 36% goes for this and 23% are asking for repeat urine culture and sensitivity. So let's see what Martin has to say on this. Over to you, Dr. Martin.
I have a slightly different idea in this particular case. I'll tell you why. I'll substantiate why. So whenever we get a report of plenty of numerous cells in urine, we have to make sure that certain things, some basic things have been, pakka. The first thing is to rule out sampling error. The midstream clean catch may not be there. And that should be insisted on. You have to make sure that is done. And if there is an indwelling catheter, the sample has to be taken directly from the catheter tubing. And the main thing is, urine is a very unstable fluid, and the composition changes as soon as it is eliminated from the body. So it should be examined fast in 2 to 4 hours. We never know when a lab who's loaded with lot of samples, when do they examine a urine sample? We never know. We have to try to make sure. In case there is some delay, there is some guidelines saying that you can refrigerate it for 2 to 8 degrees Celsius over up to 24 hours. But then if you have to examine it, you have to rewarm it again. That is a very cumbersome procedure. So a freshly collected sample, proper method of collection and proper timing of examination, we have to ensure, which is very difficult. Before going on deep into this question, we have to know some basics. That is the immunology of a urinary tract infection. The main thing harbors around the uropathogen, because if the uropathogen is very virulent, then you had it. Many of the uropathogens, especially our Klebsiella, E. coli, have got this variety of virulence factors. These virulence factors are used for adhesion, nutrient release, immune evasion from the host immune system, nutrition and iron acquisition, evasion of defense against immune cells. All these are virulence factors that are expressed by the uropathogens. But against these uropathogens, virulence factors, our urinary tract also has some defenses. So here you can see there is one bladder where there is no indwelling catheter. This is another urinary bladder with an indwelling catheter. So let's see this urinary bladder. So whenever there is contamination of the periurethral area with uropathogen from the gut, from the vaginal canal, etc., these pathogens try to colonize this area in the perineum. From there, they try to migrate into the urinary bladder through urethra. In females, since the urethra is too short, the transition is faster. So the organism uses all its virulence factors to establish itself here by forming a biofilm. And how are these defended? One, the primary defense, as I already told, is the urethra. The second defense is the urinary pH. The urinary pH itself is inhibitory to the growth of microorganisms. Apart from that, the urothelium itself, that is the transitional cell epithelium of the urinary bladder, has got many capabilities by which bacteria. That is how, because it has got glycosaminoglycans, which can retard bacterial pathogen adherence. They have a lot of multinucleated umbrella cells, which can inhibit the deeper penetration of these uropathogens. Then they have these glycoproteins called uroplakins, which can also again prevent the adhesion of these organisms. And even the bladder wall has got some components of innate immunity and acquired immunity, which protects the bladder wall from getting infected. But if this fails, the infections get established here and later it ascends up the urethra to cause pyelonephritis. If it is a tendency of these organisms to produce more and more fibrinogen, this fibrinogen helps to form a biofilm over the catheter and helps to establish itself as an infection. So these are the basic ways by which the urinary defenses and the uropathogen establish itself in the urinary tract. Certain words we have to be very clear. See, pyuria. What is pyuria? Pyuria just means that urine WBC more than or equal to 10. So it just shows that there is some form of inflammation happening. It is more of a negative predictor value. If pyuria is not there, then if it is not there, it is almost 85% sure that you are not having a urinary tract infection. But if the pyuria is there, then whether urinary tract infection is there or not has to come from further evaluation. So, and the next thing by which we use leukocyte extraase. So this leukocyte extraase, as we all know, it is an enzyme released by lysed WBCs, which acts as a surrogate marker of pyuria. And we also know about urine nitrate. So this gram-negative bacteria like E. coli can convert nitrate to nitrite. So false positive this is how it indirectly detects the presence of a gram-negative bacteria. So this is the urine dipstick. What pyuria is, you have to understand one more terminology. What is asymptomatic pyuria? So there might be a situation when there is pyuria, that is, there is urine WBC more than 10. That clearly shows that there is some form of inflammation, but the patient is totally asymptomatic. I'm sure that every one of us might have faced this. Urine might be showing plenty of WBCs, and the patient won't be having any symptoms at all. So that is called an asymptomatic pyuria. So whenever you see an asymptomatic pyuria, these are the differential diagnoses that should come in your mind. Most probably it is a recent resolving infection. And if it is not an infection, it can be the others which I have mentioned below. It could be even acute interstitial nephritis. It could be some foreign body in the urinary tract like a Foley's or a digestion causing pyuria. It can be a totally unrelated bladder growth. Lupus nephritis patients are notorious to present with pyuria, often mistaken for an infection and treated inappropriately. In post-transplant patients, early acute rejection can present with pyuria. So asymptomatic pyuria means the patient is having no symptoms at all, but urine WBCs are more than 10. Now, this is an image I am sure every one of you might have seen. If you are doing POCUS point of care ultrasound very frequently, you most likely might have come across these two pictures. And you might have even seen some radiologists reporting cystitis, showing these printouts with the ultrasound report. So here you can see this is the ultrasound of the urinary bladder. Here in the urinary bladder ultrasound, you can see these dot structures which are floating around. So these are just sediments which are floating around in the urinary bladder. So here is another patient has settled into a layer-like formation. So this shows that there is some inflammation going on in the urinary bladder and some sediments have been formed, and that is circulating in the urinary bladder lumen with the urine. So let's come to another term called asymptomatic cystitis. So here you have urine WBCs more than 8 to 10. And there is definite evidence of some inflammation of the urinary bladder, but the patient is totally asymptomatic. So there might be a radiology report showing that the bladder wall is thickened or there is some intraluminal debris in the urinary bladder, but the patient is totally asymptomatic. So these are conditions that we very commonly see in our practice. So whenever we see such patterns, you should remember the term colonization. Colonization is different from infection. The presence of bacteria in any bodily site without causing any symptoms or immune response. And here the bacteria live harmlessly within the body, and often this happens in areas like urinary tract and upper airways. And sometimes some form of inflammation might be evident in the form of urine WBC positivity, urine pyuria presence, but the patient is asymptomatic. So these are cases of asymptomatic cystitis. So that is when you are evaluating a patient who has had a severe infection before, now presenting with asymptomatic cystitis or asymptomatic bacteriuria, you have to make sure that there is no underlying risk factor which has predisposed that patient to that particular condition. That is why in the poll question that posted above, I feel this patient should undergo a detailed gynecological and urological examination. Because many a times when we evaluate such patients, we find one of these abnormalities, which we often miss because during our busy OP, we might not get the time to do it ourselves. We have to refer it to the gynecologist to do a proper examination. But this thing is usually fruitful. When we send these patients for a gynecologic evaluation, it is not uncommon that you get a call from your gynecologist saying, oh, doctor, the patient that you sent had a grade 3 prolapse or a significant large cystocele. The patient had got significant vaginal discharge, purulent vaginal discharge. So a gynecological evaluation is must, especially in this particular case scenario where our patient was having diabetes, elderly female, postmenopausal, who had presented with a significant complicated UTI and now is in recovery. We have to make sure that this doesn't happen to her again. So a proper gynecological examination is what I think is most useful here. And many a times we get ectopic vaginitis. So because of ectopic vaginitis, the flora of the perineum will change, thus leading to more and more uropathogens to occupy that area and cause repeated infections and asymptomatic urinary changes. Many a times if the patient is having indwelling stents, indwelling long-standing catheters, then also you can get sterile pyuria asymptomatic pyuria or asymptomatic cystitis-like picture. So this particular patient that we discussed underwent a detailed gynecological examination which showed ectopic vaginitis. The vaginal wall, rugosity, everything was lost. There was some mild discharge also. So this patient was treated with vaginal estrogens. And since patient is asymptomatic, she was discharged. So after 2 weeks, the urology team contacts you. The urology team contacts you saying that, okay, the patient has now recovered. Now we want to remove the DJ stent. We had done a urine routine examination. Patient is asymptomatic, but we have done a urine routine examination. And again, the urine pus cells are numerous. And we went ahead and did a urine culture and sensitivity report again. That report again shows Klebsiella, which is MDR now. The initial Klebsiella was carbapenem sensitive. Now this Klebsiella, which has turned up now, is multi-drug resistant. So the urologists want to know whether we should push the patient for another antibiotic therapy or not. So Dr. Jyotipriya, the next poll.
Okay, moving on to poll 2. Next slide. So the second poll is asymptomatic bacteriuria patient planned for DJ stent removal, urine culture and sensitivity showing MDR Klebsiella. So what's your approach? A, proceed with DJ stent removal in standard risk consent. B, proceed with DJ stent removal with high risk consent. C, proceed with DJ stent removal followed by IV antibiotics for 1 week. D, wait for synergy test report. Dinesh, can you launch poll 2? Yes, so poll 2 is there. So the question is there and 4 options. Okay, I think time is up. Dinesh, you can close the poll and launch the result. So 53% are of the opinion proceed with DJ stent removal followed by IV antibiotics for 1 week. And few are of the opinion to proceed with high risk and standard risk consent. So Dinesh, you can close the poll result. So at this point, I would like to get the opinion from our expert panel, Dr. Sambat sir. Sir, how will you approach a case of asymptomatic pyuria, also a case of asymptomatic cystitis as well? What will be your evaluation strategy and what all investigations will you be doing? And secondly, pertaining to this case which Martin had told, how will you manage such a patient, a case of asymptomatic pyuria with MDR Klebsiella planned for DJ stent removal, your line of management? Over to you, sir, regarding your take on this topic.
I was muted. See, whenever a patient develops a very severe urinary tract infection, you need to give time for the pyuria to settle. It will take anywhere between 4 to even 8 weeks. As long as the patient's general condition is better and the patient is doing well, and another week of an antibiotic, and then we stop and wait for them. See, the asymptomatic pyuria, unless it produces clinical symptoms, I will not be in a position to manage them further because antibiotic resistance is looming large, and unless they develop complications, I will not be managing them with prolonged course of antibiotics. This is number one. Number two, in India, whenever somebody has recurrent urinary tract infections, tuberculosis should be high on the alert. And you have repeatedly, we have seen diabetics presenting with recurrent bacterial infections, and with each infection very incompletely treated, very incompletely resolving. Ultimately, if you do investigations for tuberculosis, you will hit it. And even if you are not hitting it, there is no harm in giving an empirical anti-tuberculous therapy for these patients. This has been my practical management of these patients.
Thank you, sir. And sir, one more question regarding the scenario where you have to proceed with the removal of DJ stent in this case. What will be your approach?
No, I will definitely remove the DJ stent because DJ stent itself could be one of the important harbinger of biofilm and also prolongation of these bacteriuria and also prolongation. So as long as the patient is doing well without any loin pain, so clinically also you have to take a very important decision. The patient is doing well, eating well and feeling well, there is no loin pain, there is no residual obstruction. After, say, 4 weeks, the 4 weeks is the time that I personally use for removal of the DJ stent. After that, I wait and watch.
Thank you, sir.
Yeah.
Now over to Dr. Martin for his take on this.
So there are specific guidelines like when to treat asymptomatic bacteria. So prior to an invasive urological intervention, you are supposed to treat asymptomatic bacteriuria. In pregnancy also, the treatment is required. Immediate post-transplant period is slightly a gray area where some centers, they say that the first immediate post-transplant period of 1 to 2 months is a very risky area. And in that period, asymptomatic bacteria should be treated. So first, let us take the urological procedure thing in asymptomatic cystitis or asymptomatic bacteriuria. Urological procedures associated with significant mucosal bleeding and trauma. So these kind of procedures like TURP surgeries, bladder resection surgeries, percutaneous stone removal surgeries, these come under urological procedures associated with significant mucosal bleeding and trauma. So this is like if this procedure is done in a patient who is having an asymptomatic urinary tract infection, so it is like operating in a heavily contaminated surgical field. So we know whenever we operate in a heavily contaminated surgical field, the risk of serious post-operative sepsis is always there. So the IDSA guidelines of 2019 clearly state that whenever you have an asymptomatic cystitis patient who is undergoing such a procedure, then the infection has to be treated. But there are uncomplicated diagnostic procedures like cystoscopy, a Foley's catheter placement, a DJ stent removal. So these are uncomplicated diagnostic procedures. So they say that these kind of procedures doesn't require a treatment with empirical antibiotics or any of them. But definitely just before the procedure, many urologists give a single shot of antibiotic just at the time of admission and just when the patient is shifted into OT. That is different. But otherwise, this simple procedures, there is no need for waiting for another culture report. You can directly go ahead. So asymptomatic cystitis prior to urological procedures, but in emergency procedures, definitely, if there is an emergency, major procedure has to be done to save the life of the patient. So in that case, you have to start the patient on empirical IV antibiotics and do the procedure. But in an elective procedure, it is better to make sure that the infection is properly treated, then only major urological procedures should be done. The US and UK, some of these centers use this chemical called methenamine hippurate. So this acts by forming formaldehyde, and it secretes the formaldehyde into urine, making the urine acidic and thus creating a clear area for doing the surgery. But it's said that this molecule is not enough. At least you have to use a third generation cephalosporin or a fluoroquinolone. Some centers use trimethoprim and sulfamethoxam combination. But whatever be the use, they always prefer a short course rather than a prolonged antibiotic therapy. So with all these, it is almost clear that the IDSA is so scared of drug resistance. They are having so much restriction on the use of antibiotics unnecessarily. And even if when you are using it in a required scenario, they specifically insist that the duration of the antibiotic therapy should be small. Apart from the antibiotic resistance issue, this also is helpful for the patient. It decreases the hospital stay. It decreases the cost of therapy. And along with that, you get an extra advantage that there is less risk of resistance organism coming up in the coming years. So what happens in pregnancy? Asymptomatic bacteria occurs in 2 to 7% of pregnant women. So the main thing is, if you don't treat asymptomatic cystitis or asymptomatic bacteriuria in pregnancy, these can lead to complicated urinary tract infections like pyelonephritis. So in the ester years, the prevalence of pyelonephritis in pregnancy was 20 to 35%. So just by the intervention of treating asymptomatic bacteriuria in pregnancy, this 20 to 35% came down to 1 to 4%. So there's a significant change in the number of pyelonephritic incidents in these patients when they are treated appropriately. And it also, some anecdotal and some, though the evidence is not that strong, they say that it reduces the risk of preterm labor and thus reduces the chances of the baby being a low birth weight baby. So the antibiotics which they prefer in pregnancy is nitrofurantoin or beta-lactam antibiotics, usually an ampicillin or a cephalexin. And they suggest that these should be given for 5 to 7 days. 5 to 7 days of antibiotics, very clearly mentioned by ACOG guidelines. And the only exception that they say is phosphomycin. Since phosphomycin sachet can be used, it can be used as a single dose, which can act for at least 5 to 7 days by itself and try to contain the antibiotic, the infection, the asymptomatic bacteriuria. One more thing the ACOG guideline says that once you have done this treatment, there is no need to recheck. there is no need to recheck, and there is insufficient evidence to recommend for or against repeat screening during pregnancy after a negative initial culture report. So that also they have clearly mentioned. So asymptomatic cystitis in post-renal transplant patients, the cotrimoxazole that the patient receives as prophylaxis itself is protective, but there can be indications where asymptomatic bacteriuria is present in post-renal transplant patients. And the general dictum of the IDSA guidelines of 2019 says that there is no indication for treatment. And there is guidelines from American Society of Transplantation Infectious Disease Community practice, and so they again say that the problem is more with antibiotic resistance, and they don't consider asymptomatic bacteriuria as a disease state at all. And apart from that, they even go and say that this actually is protective, saying that there is a concept called bacterial interference. So it outcompeting the disease-causing microorganism by the resident microorganism, and this prevents major infection. So treating this would actually bring harm than, but still it is very center specific. Many centers always think that the first month of post-transplant is very critical, and if they find asymptomatic bacteria, many centers they treat asymptomatic bacteriuria in the first month post-transplant. But after the first month post-transplant, it is very clear that asymptomatic bacteria does not require treatment. But we have to keep on looking at the cause. We have to do detailed evaluation of the patient for the reason why it is persisting. So this, I think, is a very common picture when you see long-standing patients, elderly patients. So this is what is called as a purple bag syndrome. So this is very common in patients who are demented, elderly, patients who are having constipation, long-standing urinary catheter, and alkaline urine. So in these patients, when they have food, the tryptophan in the food is converted to indole by the intestinal bacteria. This happens because these patients suffer from long-standing constipation. The intestinal bacterial overgrowth will be there. So indole is formed. The indole is taken up through the portal circulation into the liver, where the indole is conjugated with sulfate by hepatic conjugation to form indoxyl sulfate, indican. This indican is then secreted into the urinary tract. In the urinary tract, the bacterial phosphatases and sulfatases in the urinary tract converts this into indoxyl forms, which in the presence of alkaline urine becomes blue, which is called indigo. And it sometimes, very rarely, you can get a red color also when it is called indirubin. So this is another condition where no treatment is required if the patient is asymptomatic. Usually in these patients, what we do is we change the catheter, we treat the constipation, we make sure that the general perineal hygiene is maintained. Many of the times, all these things will not be properly done. Perineal hygiene is maintained, constipation is treated, the Foley's bag is changed, and many times, if it is elderly females, there might be ectropic vaginitis, which has to be treated. If you do all those, the things, the purple bag syndrome goes away by itself. So asymptomatic cystitis in immunocompromised patient, see, diabetics, old, frail, who are living in institutions, HIV patients, neutropenic patients, spinal cord injury patients with voiding problems who are on long-term urinary catheters. None of these patients require treatment for asymptomatic cystitis or asymptomatic bacteriuria, very clearly mentioned in the IDSA 2019 guidelines. This is all for preventing bacterial resistance, which is a big problem now. So our patient underwent the DJ stent removal without any complication. Then the patient is reviewed with you after 2 weeks again. The blood sugars and blood BP are well controlled. The creatinine is around 2.5. Again, the urine albumin is showing 1+, and urine pustules is numerous. There is proturia. So now we are planning to add our next armamentarium of diabetic kidney disease management, the SGLT2 inhibitor. It was stopped earlier when the patient became very sick. So now, whether or not to add the SGLT2 inhibitor. Dr. Jyotipriya, poll 3.
So moving on to the third poll. Regarding restarting SGLT2 inhibitors in this patient with asymptomatic cystitis, what will be your approach? Option A, should not have been stopped for this patient. Option B, should have been restarted after the initial 14 days of IV antibiotics itself? Option C, since DJ stent is removed, we could restart now. Option D, restart only when asymptomatic pyuria clears. Dinesh, can you launch poll 3? Yes, poll 3 is on the screen. 4 options are there. You can give your opinion. Okay, I think we can close the poll. Dinesh, close the poll and launch the results. So 35% majority, no, actually there is a tie between C and D, almost same. 35% have opted that since DJ stent is removed, we could restart now. And 37% is of the opinion restart only when asymptomatic pyuria clears. So Dinesh, you can close the poll. So at this point, we can get the opinion from our eminent senior, Dr. Satish sir. Sir, what's your approach in this scenario on restarting SGLT2 inhibitors in a patient who had pyelonephritis and was on DJ stent and now coming for follow-up with urine showing pyuria but no symptoms? So what is your take on this, sir?
Well, this is a problem where you have to make a clinical decision. I don't think it's really covered by guidelines or anything like that. So if you look at these studies, there is no increase in urinary tract infections except balanitis and vaginal candidiasis with this SGLT2 inhibitors. But in practical speaking, will we really restart? I don't know whether any of us have the courage to start antibiotics once this infection clears. I wouldn't wait immediately after DJ stent, but if the asymptomatic pyuria remains like that, some of them, they never clear their asymptomatic pyuria also. So they continue to have pyuria for months and years also. So will you restart in them? That's a problem. So probably I will do it. I will restart at some time, but not immediately after stent removal, but not even after the asymptomatic pyuria, but somewhere in between when I feel it is okay. I'll get a Goldilocks zone or something like that. That's what I would do.
Okay, thank you, sir. So it's a gray area where you have to apply your clinical logical skill.
Yeah.
So at this point, I think I'll ask one lighter question to Dr. Sonu. You are starting a patient on SGLT2 inhibitors, and on follow-up visit, patient is showing numerous pustules in the urine analysis, but no symptoms of UTI. So in this scenario, what will be your strategy in continuing SGLT2 inhibitors, and how will you follow up this patient?
Thank you, Jyotipriya, for that question. So for this patient who is on SGLT2, who doesn't have any urinary symptoms, presenting to you for routine follow-up, and for some reason you have done a urine examination, which shows numerous pustules. First and foremost, what I would be looking is for whether there are any clinical symptoms of any urinary tract infection. If there are any symptoms, then I would stop SGLT2s immediately. If there are no symptoms of urinary tract infection, then I would be looking for some other causes of asymptomatic pyuria. Like Martin has mentioned, if there is any indwelling urological devices, or is there any acute interstitial nephritis, is there any recent antibiotic therapy? If such things are not there, then I would most probably stop the SGLT2, send the urine cultures, and wait for the cultures to come back. If the cultures are sterile, then I would be happily continuing SGLT2 inhibitors. If at all the cultures are not sterile, if it is showing an organism and patient develops some symptoms, I would try to treat that infection. And following a mild urinary tract infection, I usually restart the SGLT2s after 1 week of resolution of symptoms. That's what I usually do. Thank you.
Thank you, Dr. Sonu. It's very clear now. So anyway, let's proceed with Martin's presentation, and Martin, what Martin has to say on this. Over to you, Martin.
Satish sir is very right in saying that it is a slightly dicey area. See, asymptomatic cystitis and SGLT2 inhibitors. Now large recent population-based cohort study, it has really recently shown that an SGLT2 inhibitor use was not associated with any serious or non-serious UTI. So if it is indicated for diabetes or heart failure, don't discontinue the medication in asymptomatic bacteriuria. Don't discontinue even in mild UTI. That is what many of the guidelines say. Okay, not guidelines, studies which have produced their results say. But see, what happened actually with SGLT2 inhibitor in 2013 when canagliflozin was released, in 2015, FDA released this drug safety communication. That was not for some mild infection. It was for 90 cases of life-threatening urosepsis and pyelonephritis, which was detected in post-marketing adverse event reporting. And again in 2018, FDA issued another warning saying that there was 12 cases of Fournier's gangrene. Fournier's gangrene are infections which are very difficult to treat with the use of these medications. And the sick day rule we all know. So given this big history in background, how confident will we be to continue these SGLT2 inhibitors in the presence of active UTI? It is a question. It is really a question. But we can hit a middle ground. For example, for new initiation of SGLT2 inhibitor, if there is no contraindication and there is asymptomatic bacteriuria with past history of GU infection, but the patient is totally asymptomatic, then it will be it is not contraindicated. But recurrent urinary tract infections are happening. Then you have to make sure that you have to make sure that why it is happening. You have to try to evaluate the cause and also treat the condition. For example, if there is some perineal hygiene issue, treat that. If there is some early signs of infection, you have to intervene fast. And if, as Sonu sir has told, if the patient is having an active infection which develops during SGLT2 inhibitor, it is always safe to stop, treat, and then reinitiate. But though many of the guidelines kind of force feed us saying that it is okay to continue, we should always take it with a pinch of salt. Now the problem arises with this study. So this study came in European Heart Journal. It is a study from Hong Kong. I think most of you might have seen it. Here they have brought in a term called incident UTI. Incident UTI as a risk factor for major adverse cardiac events and renal adverse events. The incident UTI itself becoming a risk factor for MACE. For example, this patient, when a patient develops incident UTI, the cumulative incidence of primary cardiac composite outcomes increase. When a patient develops an incident UTI, the cumulative incidence of primary renal composite outcomes also increase. So in this background, where your SGLT2 inhibitor protects the renal and the cardiac part, and in this background, when you stop the patient of SGLT2 inhibitor, this is what happens. When you discontinue the SGLT2 inhibitor, the cumulative incidence further rises. So this is kind of scary. I don't know whether the study was put to scare us or forcing us to use SGLT2 inhibitor even in cases of incident UTI. But this again, we have to take it with a pinch of salt. We have to take decisions on case-to-case basis, assessing each case clinically and then taking a decision, as Sonu sir told. So it will be always used to follow the basic sick rule day. When a patient is really sick and the patient is having severe infection, it shall restart it. You can be more lenient given the large amount of evidence that you have now. So this patient again has come back to you after 2 months. Again, the patient is asymptomatic. There was irregular diabetic medication. The blood sugars are a bit high now, but again the urine has showed numerous pustules. And you get a call from your lab technician who is examining the urinary sediments, saying that he has found something. You run to the lab and see this finding. This is a urine microscopy showing. You can see this. This is actually a hyphae. This is a fungal hyphae, and you can see this small round things. These are budding yeast. So this is actually an asymptomatic patient with active fungal elements in her urine. She is having a very poorly controlled diabetes. She is showing fungal elements in her urine, but she is totally asymptomatic. Dr. Jyotipriya, poll 4.
So moving on to the next poll. Poll 4, asymptomatic cystitis patient with fungal elements in urine. What is the next step? A, send urine fungal cultures and treat as per culture report. B, send urine fungal cultures and start on oral fluconazole. C, stop SGLT2 inhibitors. D, continue SGLT2 inhibitors and control blood sugars. Dinesh, can you launch poll 4? Yes, poll 4 is on the screen. 4 options are there. So you can share your opinion. Okay, I think Dinesh, you can close the poll and show the results. So this is also like a little ambiguous area. I think 35% opted to continue SGLT2 inhibitors with blood sugar control, while some asked to stop SGLT2 inhibitors and some to send fungal cultures. So I think you can close the poll, Dinesh. So at this point, is Iqbal sir there? Iqbal sir? Okay, Srilata madam?
Yes.
Okay. Madam, what is your take on this question, as well as how will you manage asymptomatic candiduria in a renal transplant patient? So first, if you are getting a fungal element in asymptomatic cystitis patient, what is your approach in this case scenario? How will you proceed? And in transplant patient, what is your general approach?
Regarding SGLT2 inhibitors in this scenario or not?
Ma'am, patient is already on SGLT2 inhibitors, now with fungal elements in the urine, and patient is asymptomatic.
If it is a fungal infection, better to stop SGLT2 inhibitors and start the patient on fluconazole or the culture sensitive antifungal elements. In post-transplant, definitely you have to stop SGLT2 inhibitors. Asymptomatic bacteriuria, there is no indication for stopping. Continue may give antibiotic prophylaxis if it is a female uncontrolled glycemia and persistent pyuria. I used to give a small dose of nitrofurantoid as a prophylaxis and continue with SGLT2. But fungal elements, it is better to stop SGLT2.
Okay. Thank you, ma'am. So now we'll see what Martin has with him to shed more light on this topic. Over to you, Martin.
So candiduria, whenever we see candiduria, we have to look at these 3 points, whether it is contamination, colonization, or infection. The contamination we have ruled out by different methods, but colonization and infection, it is very difficult to differentiate. And sometimes repeated cultures might be necessary. Whenever you get candida elements in urine, one important thing that you have to always rule out is whether there is some form of obstruction in the urinary tract, or if there any indwelling catheter, or is there any indwelling degescence. All these foreign bodies can again help to harbor the infection again and again. Whenever there is a symptomatic patient with candiduria, definitely the stopping SGLT2 inhibitors are no doubt it has to be stopped. But if the patient is totally asymptomatic, no symptoms at all, it is just an incidental finding that you did a urine microscopy and you saw a few fungal elements. Whether SGLT2 inhibitors has to be stopped, it is again, we have to take it in a case-by-case basis, how the patient's history was, whether he had past history of fungal infections, which are very difficult to treat, how the blood sugars are controlled. Taking all these into picture, we can take a decision. But the guidelines per se say that asymptomatic candiduria without any active features of infection who are on SGLT2 inhibitor, you needn't stop. But except in patients who are having neutropenia, prior or urological procedures. So in these patients, it is always justified to stop. And asymptomatic candiduria in renal transplant, as Madam said, presence of more than 10⁻³ colony forming units is required to show that it is a significant infection. And when it's asymptomatic, no treatment is usually advised. But if a urological procedure is planned or a neutropenic patient, definitely these patients should be given a course of fluconazole or amphotericin B, whichever is appropriate in that particular patient need, treated, then only a urological procedure should be done. So next we will move on to this particular topic called sterile pyuria. Jyotipriya, I think.
Host, please mute all hosts.